to the last, but also very important presenter, Dr. Naku.
Hello.
And the great party will end with you. At the start of the party.
I'm happy for that. Thank you very much.
You deserve it.
Okay, so in this part of the clinical cases, what I tried to do is actually to classify the cases according to conditions. For example, LVH, phenocopy, DCM, myocarditis. And the reason that I did that was because I wanted to facilitate consolidation of knowledge that people have already taken through these 2 days of this very, very significant course. So I will start from the first case, which is an LVH case. 85 years old male presented with shortness of breath. He had an echocardiogram which showed significant left ventricular hypertrophy, concentric, with preserved systolic function and diastolic dysfunction. He was referred for the cardiac MRI for the further assessment of this LVH. So in the upper row, you can see the cine images. Indeed, there is, you can see that there is concentric hypertrophy. There is reduced longitudinal function. There are dilated left atrium. There is a small jet of tricuspid valve, but the function, TR, but the function of the left ventricle, as you can appreciate, is preserved. Then we proceeded with the short axis late gadolinium enhancement. And you see here, you can see a multi-view where you can see that there is an extensive circumferential subendocardial late gadolinium enhancement from basal segment to apex. And as the radiographers told us, it was very difficult to null the myocardium, implying abnormal kinetics, myocardium and blood kinetics, which is characteristic in cardiac amyloidosis. We proceeded with the mapping technique. And this is case 1, sorry about that, this is typo. So in the first row, you can see the native T1 and the T1 post-contrast. So we saw that the T1 values in native T1 mapping were very high. And you can see here the color is completely different. You can see the scale here and the color is more closer to orange or yellow, which means that it is high. And indeed, we calculated it at 1,231 milliseconds, which was high for our scanner. And then after contrast, we calculated the ECV. You can see that the color here is almost the same with the blood pool, and the ECV gave us a very high number, 63%, which is pathognomonic for cardiac amyloidosis. And the T1 mapping technique is very important in differentiating LVH phenocopies, and especially in 2 cases, the amyloidosis, where it is very high, and the Anderson Fabry disease, where it is very low. So keep that in mind and always use T1 mapping when you have an LVH phenocopy. And there was a question if we need T1 mapping even after contrast and why. So here there are 2 different cases with, as you see, similar degree of LVH. You can see that in the late gadolinium enhancement PSR sequences, which is qualitative technique, there is almost similar amount, a little bit more in the second amount of late gadolinium enhancement, maybe a little bit more in the second case. And you can see that the ECV, when we use quantitative technique, the ECV in the second case is almost the double of the first case, which means that the amyloid deposits in the second case are much higher, although this patient has the same degree of LVH with the first patient. And it is very important, this information, for 2 reasons. One is the prognosis, and the second is we can follow up with these patients after treatment with cardiac MRI and TCV mapping to check for response to the treatment. Case 2, this is another LVH case. I saw this patient in my clinic a few months ago. So he was referred from local hospital with a diagnosis of hypertrophic cardiomyopathy. No genetic testing was done. However, the patient was labeled as HCM for many years. He is a 50-year-old gentleman. You can see that the GLS is very low, especially the basal lateral wall. And because I'm clinician and I love the ECG, you can see here the ECG, the deep T-wave inversions, and also the short PR interval. We proceeded to cardiac MRI for further assessment. Indeed, we saw that there is LVH, and in the T1 mapping, there was very low native T1 values in almost all the ventricle, apart from the area in the basal lateral wall, where the T1 were just a little bit higher than the normal one, 1075, 1080 milliseconds, just a little bit high for our scanner. And this corresponded to this area of in the late gadolinium enhancement sequences of high signal in the mid wall, in the basal lateral wall. So this is characteristic for a Fabry disease. The suspicion raised. We sent blood tests. He is a female, for serum alpha galactosidase level, which was low, and we confirmed the diagnosis with genetic testing. Very important to put the diagnosis on time, because this patient is important to start the treatment, the replacement treatment, as soon as possible. So all LVHs are not HCM. Case 3, so this is another LVH phenocopy. So you can see here, you can appreciate, I'm afraid the videos are not playing here. You can appreciate that there is a symmetrical VH in the basal septum, basal anteroseptum, basal anterior wall. There is correlated mid-wall late gadolinium enhancement in the hypertrophied areas, and which is also correlated with high native T1 values. And we proceeded with perfusion mapping in this gentleman as well, because he reported some atypical chest pains, and he also had a non-sustained VT on Holter monitor, and we saw that there was a perfusion defect, which, however, matched the hypertrophied areas. So you can see the basal anteroseptum and the apical inferior and apical lateral walls, where there was a thickened myocardium. Importantly, the CT, we proceeded with CT coronary angiogram, which showed normal coronary arteries. So this is a case of hypertrophic cardiomyopathy. The diagnosis confirmed genetically with with pathogenic variant in MYBPC3, sarcomeric mutation, and this perfusion defects is nothing else but correspond to microvascular dysfunction due to LVH. Another LVH phenocopy, very recent case, this 33-year-old woman who has diagnosis of lupus dermatomyositis overlap under dermatology in November 2023. She was referred to me due to family history of hypertrophic cardiomyopathy. So when I saw her in the clinic, she reported some general symptoms. So she reported some myalgia, joint pains, reduced appetite, feeling generally unwell. She also reported some chest pains and palpitations, and from the history, I understood that she had on and off some flares of her disease, of her condition, lupus. So I proceeded with some more tests. The CRP was below 1. She had mildly increased troponin, which was static, and increased NT-proBNP. As you can see here, the ECGs abnormal. We will agree, everyone, with T-wave inversions in lateral walls and the inferior walls. The transthoracic echocardiogram showed mild to moderate concentric LVH with maximum wall thickness 1.8 and mild mitral valve sum and LVOT at rest, with no significant increase with Valsalva. There was also the impression of near complete apical obliteration and contraction. So we proceeded with a cardiac MRI for further evaluation. And indeed, you can see here that there is hypertrophy, almost concentric, which extends to even to apical segments with apical obliteration, and the LV function was normal. When we proceeded with the T2 weighted images, we saw that there was a slightly increased signal in diffuse, but more prominent in the mid to apical segments, where we saw more prominent LVH. As you can see here, there is different in signal. Of course, keep in mind that T2 weighted is a qualitative technique. So we proceeded with the mapping techniques. The T2 mapping showed that in the areas of the LVH, the T2 value was high at 76 milliseconds, and these high values corresponded also with high values in the T1, with the T1 mapping technique, native T1 mapping technique as well. So this raised the suspicion that this is not a hypertrophic cardiomyopathy, but possibly it is myositis in the context of lupus flare, another lupus flare. So in collaboration with the rheumatologist, we decided to proceed with the CT PET. You can see very clearly here that there was diffuse increase increase uptake, in the left ventricle, confirmed actually the suspicion of our suspicion, and the patient started on rituximab. 4 months later, I saw here in the clinic again. You can see that the ECG is still abnormal, but the ECG changes, abnormalities are not so prominent. So you can see that we do not have the Sokolov criteria of LVH. We have T-wave inversions in lateral leads. We have T-wave inversions in inferior leads. And we repeated the cardiac MRI, which showed indeed the resolution of the myocardial edema. And the left wall thickness was mildly, very mildly, borderline increased at 14 millimeter, measured at 14 millimeter, 14 millimeter. However, if you notice a little bit better the apex, you will see that there is a loss of apical tapering. So in the LG images, there was no late gadolinium enhancement. And in this case, the troponin was negative. And in the context of the family history and in the context of the ECG changes, what we believe that, and I believe that the patient has, is possibly an early stage HCM where the LVH was exaggerated by the edema caused in the context of lupus-related myositis. We will continue to follow up here to see if she will evolve this phenotype, progress this phenotype more prominently. This is another case, actually is the brother of this lady, 25 years old. He also has lupus with lupus nephritis, family history of HCM, as I told you. The rheumatologist had put him on hydroxychloroquine and voclosporin, and he had, when I saw him in the clinic, he had really high systolic blood pressure. You can see the ECG. It's not completely abnormal ECG. You can see the deep S waves. You can see some fragmentation. Of course, this patient does not have the T-wave inversions that the sister had. And we proceeded with transthoracic echocardiogram, which showed severe concentric left ventricular hypertrophy with no sum, normal size and systolic function, and ejection fraction calculated at 61%. We requested also a 24-hour blood pressure monitor to check the blood pressure readings, and this showed constant, long-standing, and constant high blood pressure readings. And of course, we proceeded with a cardiac MRI trying to assess further this LVH. You can see nicely that there is a concentric. The MRI confirmed the diagnosis of the LVH. There is concentric LVH affecting almost all the segments of the left ventricle with very good left ventricular systolic function. And in the LG images, we didn't see any late gadolinium enhancement. I can tell you from the native T1 mapping, the patient was a little bit claustrophobic, so we tried to miss some images if we could. I can tell you that the T1, from one slice that we took, the T1 values was slightly high. And considering that the blood pressure was high, after liaising with the rheumatologist, we decided, and they decided to stop voclosporin and reassess him 8 months was this scan with cardiac MRI, while his blood pressure was constantly very well controlled. And you can see that the LVH regressed significantly. And actually, there is no LVH, and there is no LVH phenocopy at this stage. LGE images did not show any late gadolinium enhancement. Another case of LVH phenocopy. Sorry about the quality of the ECG. So this is a 38-year-old man who was admitted with vasculitic RAS and horizontal diplopia 9 months post-allogenic stem cell transplantation for T-cell acute lymphoblastic leukemia, ALL. The cardiac MRI, they proceeded MR of the orbits, which showed enlarged extraocular muscles, and an echocardiogram to exclude possible cardiac embolic sources. And this showed biventricular hypertrophy and spectrum myocardium. You can see that this ECG is not a normal ECG, it's myopathic ECG, as we say, with T-wave inversions in the anterior and lateral leads. And we proceeded with the cardiac MRI. You can see here the short axis stack, left ventricular short axis stack multiview, and you can nicely see that there is asymmetric hypertrophy. Maximum wall thickness in septum was measured 21 millimeter, but the LV function was normal. The LVH affected mainly the septum. We proceeded with the tissue characterization techniques, and what we actually saw was that there were areas, nodular areas in myocardium and pericardium of infiltration, which were not enhanced in contrast imaging, and which had high native T1 values in T1 mapping. And this raised the suspicion of relapse acute T-cell ALL, and the MR-guided biopsy of the swollen ocular left rectus muscle confirmed the diagnosis. The patient started chemotherapy, and surprisingly, look the images that we took at 1 month. 1 month follow-up CMR. You can see that the heart almost normalized. There is no LVH, there is no infiltration, and with normal T1 mapping and normal late gadolinium enhancement as well. So what I wanted to tell that with these different cases of LVH phenocopy, keep in mind that LVH does not mean hypertrophic cardiomyopathy. There are different clinical scenarios that we need to exclude, especially amyloidosis and Fabry disease. Very important to be excluded, because we can, if they are diagnosed earlier, we can change the natural history of the condition. So this is a slide from the recent guidelines in cardiomyopathy, where we actually introduce the cardiomyopathy mindset, which means that we have the phenotype, and based on phenotype, we try to based on phenotype and the symptoms and the clinical history and the family history, we try to put the diagnosis. T1 map, very important in clinical practice for LVH phenocopy. Very low T1 map means lipomatous metaplasia or fat. Very high, think about very high T1, think about amyloidosis. Case 7, 28-year-old male. Now we will move from LVH phenocopy to DCM phenotypes. So in this case, we have a 28-year-old male Caucasian who is athlete, actually. He is doing 20 hours per week rugby and training at a club level. He attended a pre-participation screening event. He didn't have any remarkable family history, and his physical examination was completely unremarkable. So you can see that his ECG is not a normal ECG. There are T-wave inversions in the anterior and lateral leads. There are frequent ectopics which are polymorphic, and this ECG actually raised the suspicion of arrhythmogenic cardiomyopathy. You can see that one of the ventricular ectopics, one of the type of ventricular ectopics has LBBB morphology with inferior axis as well. And the next step was to do an echocardiogram. So the echocardiogram at the local hospital showed dilated left ventricle with ejection fraction of 45% and global hypokinesia. The right ventricle was normal, with normal size, with normal systolic function. Here is his cardiac MRI images. So you can see that his left ventricular cavity is mildly dilated. If you can notice, there is no, it is the periphery is a little bit anomalous here in the anterior wall, and moving to the short axis sequences, we confirm the impaired LV systolic function at the range of 40-45% as echo showed. When we proceeded to late gadolinium enhancement long axis sequences, you can see extensive mid-wall, circumferential, almost circumferential, you can see it everywhere, late gadolinium enhancement. And you can see it better in the short axis LGE sequences. You can see the ring type mid-wall late gadolinium enhancement affecting almost all the segments of the left ventricle. This is a very typical case of arrhythmogenic cardiomyopathy, and this ring type late gadolinium enhancement raised the suspicion of desmoplakin mutation, which is usually correlated with this phenotype. So we proceeded with genetic testing, which actually confirmed the diagnosis of desmoplakin-related cardiomyopathy. And for this patient was quite important, because don't forget that he was an athlete. So according to recommendation, to exercise recommendation, patients with arrhythmogenic cardiomyopathy, with this gene mutation and with this LV function and this ECG with the multiple ventricular ectopics should not do high-intensity exercise and competitive sport, a diagnosis that unfortunately changed his lifestyle. Case 8, 51-year-old female who presented with shortness of breath on exertion, worsening the last 3 months, has a history of hypertension, family history of dilated cardiomyopathy. The echocardiogram showed severely dilated left ventricle with severe LV systolic dysfunction, and the coronary angiogram did not show obstructed coronary arteries. Here are the CNS sequences of her cardiac MRI. You can see very large left ventricle, very bad LV function. You can see that the septum, the atrial septum, is bulging towards the right septum, which actually is indicative of high left atrial pressures. No regional wall motion abnormalities. There is global hypokinesia, and then the late gadolinium enhancement showed a layer of mid-wall late gadolinium enhancement in septum, diagnosis of non-ischemic dilated cardiomyopathy. What I wanted to show you in this case, which might not be of clinical relevance, however, it is incidental findings, and we should look at incidental findings, is a persistent right superior vena cava. Another case, 48-year-old male with known pulmonary sarcoidosis and who presented with palpitations. I want to show you from the localizers and HEST images actually that they enlarge these structures, which actually represent the lymphadenopathy, mediastinal lymphadenopathy, and nodules in the lung parenchyma. The cardiac MRI, as you can see, that on the top line, the CNS sequences, there was LVH hypertrophy affecting borderline mild LVH hypertrophy affecting the septum, mainly the septum. The LV function was normal. The T2 sequences, the T2 weighted sequences did not show any evidence of edema of high signal. However, and we proceeded also, we confirmed that with the T2 mapping, which gave us normal T2 values. However, on late gadolinium enhancements, you can see that there was late gadolinium enhancement mid-wall late gadolinium enhancement in septum, affecting the septum, affecting the basal and mid-inferior wall, and this is actually cardiac sarcoidosis with not in acute phase of without inflammation. Another case, 73-year-old male with chronic thromboembolic pulmonary hypertension, referred for angiography and calculation of pulmonary and systemic flows. So here you can see the septal bounce in the left ventricle, both in systole and diastole, indicative of RV volume and pressure overload. The LV function looks preserved. We tried to see the RVOT and the branches of the pulmonary arteries in sinus, and then we proceeded with the pulmonary angiography, where I just wanted to show you that we can see very well the filling defects, as we can see in the CT, of filling defects in the branch of the pulmonary of the left pulmonary artery. I did not want to say in the clinical suspicion of acute pulmonary embolism, request a cardiac MRI. No, this is not the purpose. I just wanted to show you another characteristic, another property that MRI and another information and advantage that the MRI, cardiac MRI can have. Also, what I wanted to show you is that in this case with pulmonary hypertension, you can see that in the late gadolinium enhancement, there is extensive prominent LGE in the inferior points, superior and inferior points, which actually extend towards the septum. This is characteristic of a pulmonary hypertension case. This is another case of ASD. We discussed about that previously, actually, in the congenital session. A 60-year-old woman with large atrial septal defect. And the CMR requested for further assessment of the right ventricular size, the QP to QS ratio, RIMS, and the anomalous pulmonary vein drainage. You can see here that the right ventricular size is dilated. It's contracted, however, well. There is a small jet of TR. There is an aneurysmatic atrial septum, and the left ventricle is contracting well. Atrial stack, left atrial stack. I confirmed the diagnosis of secondum VSD, a large secondum VSD, as you can see here. And with the phase contrast imaging, we took the flows from the aorta and the pulmonary artery, and we calculated the QP to QS. Just a reminder, very good, the TOE for the assessment of RIMS. However, we can have this, we can do that with the cardiac MRI as well. You can see here the magnitude images and the phase contrast images. So we can calculate the RIM, the distance from SVC, as you can see here, from the aorta, from the inferior vena cava and the mitral valve, helping us to plan further intervention, depending on the case, of course. So this is a trial which actually showed that the cardiac MRI agrees with transesophageal assessment of ASDs in the workup for percutaneous closure. Another case, 33-year-old lady admitted due to incidental finding of large intraventricular mass protruding into the right ventricle. The patient admitted for inpatient cardiac MRI. Sorry, I forgot to tell you that the patient actually referred for the echocardiogram because he had some palpitations. Past medical history included hypertension, chronic fatigue syndrome, gastric bypass, and sleep apnea. Here is her ECG, nothing very impressive apart from a little bit low voltages. And this is the transthoracic echocardiogram. So you can see here an homogenic echo-dense mass in the septum, which is protruding into the right ventricle. So here are the CMR images. On the top row, you can see the BSSFPs, where you can see that the mass is homogeneous. However, you can see that in periphery, we have high signal. However, there is no anomalous periphery. And in the T1 weighted TSC, the signal was high, while when we suppressed, we used FAT-SAT technique, we suppressed the fat, then the mass had a low signal consistent with the fat, as you see. The native T1 mapping showed that our mass was homogeneously black. That means if you see the scale, very, very, very low native T1 values, which actually see, as we said previously, in fat. So also the first pass perfusion and the LGE showed that this mass was did not have vessels, was not enhanced. So what is the diagnosis? I think that it is clear that it is a cardiac lipoma. Another mass case, 70-year-old lady referred for cardiac MRI to assess left atrial mass detected on CT scan, performed for the assessment of vague body discomfort. So this case was a case that was referred to us from a local hospital. They did a transthoracic echocardiogram, which actually in our hospital did not show any atrial mass. In the meantime, we had the TOE images from the local hospital, which noted that there was some a relatively smooth mass on the interatrial septum, and because there was a treatment, a background of history of HER2 positive breast cancer in 2022, the colleagues locally decided to do a PET, which did not show any VDG uptake. So here are the MRI images. So you can see the mass attached to the posterior wall of the left atrium. You can see that it is homogeneous. You can see in CNS sequences there is no periphery anomalous. We can see with the BSSFP, we tried to see the mass in correlation with the other structures, like the drainage of the pulmonary vein, so to make sure that it does not cause any obstruction, as you see here. And in the T1 weighted TSC, the signal was medium. We performed mapping, T1 and T2 mapping, which showed that the mass was not homogeneous. It had higher signal, higher values in the central compared to the periphery in both T1 and T2 mapping. In the T2 weighted images, again, it was not homogeneous. However, we saw that the higher signal was more in periphery rather than in the central. And in the LGE images, we saw that there was a little bit high signal in the central part, but not in the periphery. So based on the clinical history, based on the location and the morphology, this is actually a cardiac myxoma. And we move to our case 14. This is a young patient who presented with chest pain. This was the chest discomfort. This was the ECG. Nothing impressive from the ECG. The bedside thoracic echocardiogram showed unremarkable findings because of the chest pains. We performed coronary angiogram, which did not show any obstructive, unfortunately does not play, coronary artery disease. And then we proceeded with a cardiac MRI. Unfortunately, there is some degradation in the image quality due to non-compliance with the breath hold instructions. No regional wall motion abnormalities. However, if you can see in our late gadolinium enhancement, there is just a spot, just a focal area of subendocardial late gadolinium enhancement with in the basal inferolateral wall, which corresponds to high signal in T2 weighted images. We have to do with a Minoka case, and according to guidelines, there is indication 1B to proceed with cardiac MRI in these cases. In this case, what we had was actually an embolic. What we believe that we had to deal with was an embolic event. Another case, a 46-year-old lady admitted with chest pain, high troponin levels, and inferolateral T-wave inversions on an electrocardiogram. They proceeded CTPA, which included the pulmonary embolism. She was treated with antibiotics for the respiratory infection the last week before her admission. And you can see here that the LV function was normal. However, in the T2 weighted images, there was a small area of high signal in intromyocardium in the apical septum, which corresponded with a layer of mid-wall late gadolinium enhancement. Actually, we have to do with a myocarditis. A 42-year-old female was admitted with chest pain, high troponins, high CRP. You can see here an abnormal ECG with some ST elevations in the inferior leads and lateral leads. We proceeded with coronary angiogram. The coronary angiogram showed unobstructed coronary arteries. We proceeded with the cardiac MRI, which showed mild dilatation of the left ventricle, borderline normal LV function, and the T2 weighted images. As you can see, it showed a small area of subepicardial high signal. Possibly you can see it here better in long axis. Here in the lateral, subepicardial in the lateral wall, this line of the white spots, here, and this corresponded with high T2 values. these areas corresponded to, were matched with the high native T1 values, and also with the presence of late gadolinium enhancement in the same areas. Another case of myocarditis, just an overview of the updated Lake-Louise criteria, where the CMR is the cornerstone for the diagnosis of clinically suspected myocarditis. So we need to have in the main criteria evidence of myocardial edema, either by regional or global increase of native T1 value, or regional or global increase of T2 signal intensity on T2 weighted. And we need to have non-ischemic myocardial injury determined either by high native T1 values in T1 mapping, or high ECV, or presence of late gadolinium enhancement. There are also some supportive criteria, like the presence of pericarditis, the fusion in cine images, and the systolic LV dysfunction. This is a very, very important that people should have in mind, that want to learn MRI should always have in mind. The late gadolinium enhancement can help us to differentiate ischemic from non-ischemic pathologies. Another case, this is another atypical case of myocarditis. So she is an 84-year-old woman on therapy with atezolizumab for small cell lung cancer. She presented with heart failure, but preserved ejection fraction on echocardiogram. So she was referred for further assessment of the etiology of heart failure with cardiac MRI. In the cine sequences, I will start from the extracardiac findings. You can see very well here that there are pleural effusions bilaterally. You can see that the left ventricle is of normal size, and there are no regional wall motion abnormalities. We proceeded with the T2 weighted images, where we didn't see anywhere high signal, which would be indicative of myocardial edema. However, when we took the T2 mapping, we saw T2 values diffusely increased at 70-75 milliseconds, with no corresponding areas of late gadolinium enhancement in LGA sequences. Actually, here in this case, we have to do with myocarditis related with immune checkpoint inhibitors, where I wanted to show that although there was the T2 weighted images were normal, the T2 mapping, which is more accurate in this quantitative technique, was able to diagnose the myocarditis. And I think that this should be the last case. A 71-year-old female with type 2 diabetes, active smoker, high BMI. There was no family history. She was admitted with chest pain. You can see that there are some ST elevations with Q waves already in inferior and lateral leads. She was hemodynamically stable with no symptoms or signs of heart failure on clinical examination. So the consultant on call thought that this is a myocardial infarction, and as time is myocardium, she had an coronary angiogram, which showed actually this lesion in the circumflex, left circumflex, which actually was not appreciated as as severe, at most moderate, after taking different views. On top of that, when they tried to do ventriculography, although it's not of good quality, they saw that this apical ballooning appearance. So they decided to proceed with intravascular optical computed tomography, OCT, in order to assess better this circumflex, the severity of this circumflex disease. So they didn't see any acute ruptured plaque. The LV-gram suggested Takotsubo cardiomyopathy. The patient was pain-free at that time, so they decided not to proceed to PCI. The echocardiogram performed the one day after her submission. You can see here the apical ballooning, in the left ventricle. They took also some 3D TT multi-slice, trying to show better the hypokinesias and akinesins in the apical segments. So the patient started on heart failure medications, as you can see. As we said previously, this is considered a MINOCA presentation, so we need to perform with a cardiac MRI according to guidelines. It is indication 1B, and this is what we did. Cine images does not give more information compared to echocardiogram. What we see is an impaired LV systolic function with the apical ballooning appearance, with regional wall motion abnormalities affecting the mid to apical left ventricular walls. However, when we proceeded with the tissue characterization techniques, we saw that in the LTE sequences, there was a small area in the apical lateral wall with late gadolinium enhancement, as you can see here, and with an area of low signal into this area, likely representing an MVO. However, the T2 weighted images showed high signal, which was extended beyond the circumflex territory, beyond this area, as it affected all the mid to apical segments. So actually what we have here is a dual pathology: acute left lateral myocardial infarction and Takotsubo cardiomyopathy. So they decided, we can discuss about that if you want, a few days later to proceed with the PCI in this circumflex stenosis. The first week after the admission, unfortunately, the patient had left insular infarct, and the follow-up transthoracic echocardiogram 1 month later showed a resolution of the apical ballooning and some hypokinesia of the apical lateral wall. For technical reasons, unfortunately, I could not share you the follow-up CMR sequences, CMR images. However, I can tell you that they confirmed the resolution of the apical ballooning as seen in echocardiogram, and there was only a subendocardial late gadolinium enhancement without MVO in the apical lateral wall, with overall improvement in the LV systolic function. So the learning points from this case is that the diagnosis of acute ischemic heart disease can be challenging in clinical practice when it triggers or coexists with Takotsubo syndrome. And the cardiac MRI, what actually did was, with its unique tissue characterization properties, was the key in unmasking the dual pathology, which actually we missed on angiography and even on OCT. Keep in mind, Takotsubo can coexist with coronary artery disease, and there might be thromboembolic complications due to Takotsubo syndrome, as you can see here, even 1 month after the event. So that's from me. I just wanted to close with an art feeling aspirated from cardiac MRI imaging, Smiling Heart and Valentine's Day.
Congratulations, my dear. It was great. Great journey through the party. Dina.
Congratulations. That's a great presentation. Congratulations.
Thank you.
Great.
Thank you very much.
Great.
Yeah, I think that what I tried to do is people to understand that the phenotypes might mask different conditions. So LVH is not always HCM. DCM is not always the typical DCM, but it might be arrhythmogenic cardiomyopathy or cardiac sarcoidosis. Masses are not the same everywhere. Myocarditis are not the same. We have also the myocarditis related to immune checkpoint inhibitors. And
we are very proud of you, of all the young generation, because you will be much better than we are. So this is the best prize for our generation.
Yeah.
Well, you are our teachers, so
Yes,
I mean,
but
we follow your steps.
You became much better than your teachers, and this is the best prize for us.
Yeah.
Thank you very much.
And all the best for your life.
Thank you very much.
So, Dina, anything else you have to say?
No, I think she presented all the cases at which the role, the crucial role of the key role of MRI in all these cases in everyday clinical practice. Excellent. Just excellent. Just excellent.
So enjoy life now. The party just started for you. For your own life.
Okay.
I promise that I will have even better cases the next year.
Okay, I sent you a message about SLE patients because we perform the multi-center SLE. So if you have cases, let me know in order to send you the database you have to complete.
Yes, this one is very, very interesting. Yes, thank you about that. Yes, thank you.
Okay.
Great.
Happy to
nice
have
to see
you
both, and thank you very much.
Bye.
Bye.